we have a range of speakers, and I'll pass over to Neil to introduce. Good morning, Neil.
Morning, thanks Rich. Morning everybody, really brilliant to see so many people on the call this morning. So I'm Neil Tester, I'm Director of the Richmond Group of Charities, and I'm just going to let you know who we're going to be hearing from this morning to kick off our discussion, but also just to reflect on what we heard in the first of the events that Rich talked about. There were some really strong messages that came through from the event that we held last month. Well, I can vouch for the reality of Rich's office because I actually had the pleasure of going there to do the last event, so I know it really exists. But we talked about the way that multiple long-term conditions reflect wider social inequity. We talked about the significant gap in healthy life expectancy and the way that people who live in the most deprived areas develop multiple conditions on average 10 to 15 years earlier than those in the least deprived areas. We had a really good discussion about the importance of lived experience and the way that representation really matters, and that the communities who are most affected by the challenges that have been identified need to be included wherever decisions are being made. We talked about the importance of services feeling welcoming to all and the need to foster a culture that's inclusive, and that in doing that, everybody needs to understand, their role in that. And then finally, we also touched on the importance of the evidence base. And I think there was a consensus that there is plenty of data about the scale of the problem to know why it's important we act now, but a reflection as well that we also need to think critically about the evidence that we use for local interventions and whose voices are included and excluded when we're looking at that evidence. So as Rich said, what we're trying to do today in the discussions we're going to have is to generate some really practical solutions that we can put to decision makers when we get them together, both in terms of things that primary care networks can do, but also what the wider health and care environment, including the role of local government and the voluntary sector, what else can we do to enable primary care networks to play their part in this agenda? So to get us thinking about all of that, first of all, today we're going to hear from Dr Nav Chana from the National Association for Primary Care, and then Olivia Butterworth from NHS England and Improvement. And then to set up our workshop discussions, we're really pleased that we're going to be hearing from Yasmin Ibison from Black Thrive and Rachel Brennan from Groundswell. So we're going to start off hearing sort of an overview of the landscape from Nav and Olivia, and then there'll be a chance for people to put some questions to them. And then Yasmin and Rachel will give us an overview of the really interesting projects that they've been working on, which we'll then explore in more detail in the breakout groups. So without further ado, I'm delighted to welcome Nav, who is Clinical Director at the National Association of Primary Care. Welcome, Nav.
Thank you, Neil, and good morning, colleagues, and hello from a cloudy South London at the moment. I hope the weather's slightly better in where you are. So, Neil, if I may just sort of tell you why any of this matters to me. I've now just completed 30 years as a GP in my practice, in the same practice, and I know there may be colleagues out there who've spent a longer time in and around the health and care professions than me. But and in that time, Neil, I've experienced a number of primary care reforms, which go back to the early days of GP fund holding, through things like practice-based commissioning, the development of CCGs, and now primary care networks. And I guess the reason why is important to me is that in my time as a GP, the health inequity in the poorest part of Merton where I work compared to another part of Merton a couple of miles down the road, that health inequity gap has widened, not narrowed. So currently people in East Merton spend more than 9 years in a poor health status compared to people living in a part of Merton a couple of miles away. And that gap's widened. And before, Neil, you and your colleagues comment on the quality of my practice, I'd like to say that it's broader than that, really. I think it's a broader issue about how we think about people living in particularly deprived parts of the country and geographies, and those determinants that affect their lives, both in a social, environmental sense, as well as from a point of view of health status. So just looking back, Neil, over the history of this this reform process of primary care, I think what I've learned is that for policy planners and people developing policy, four things really strike out, and I just kind of highlight those four things. The first is engaging colleagues in primary care, particularly GPs, has always been a really important part of developing primary care policy, particularly because a lot of people recognise the value of colleagues in primary care in terms of committing and shaping the way that we spend resources in secondary care. Secondly, the size of which primary care operates has always been a big debate. Do we keep it small? Do we grow it big? And there have been various attempts, I think, over my professional lifetime, to think about the scale of general practice, from very small practices to more larger corporate practices, GP federations, and now primary care networks. The thing about how we move from, how we balance between transactional based care in terms of things like counting access numbers and activity numbers, to how we keep the great value, in my view, of general practice, which is relational based care for those people who need it, how we maintain that continuity for people with their trusted healers when they require that. And there's obviously been some threats around that in the way that policy has evolved over the years. And then finally, I think the thing that we've never broken the back off is improving integration between primary care and secondary care specifically, but more broadly between physical and mental health and social care. And those dimensions that we're beginning to see become much more discussed as we've moved through the pandemic and the kind of the impact that we've noticed on health inequity there. So those, Neil, are the reasons why things have been important to me. And I've been part of a story prior to the gestation of primary care networks, which were born on the 1st of July 2019, just to remind colleagues. But there's been a whole raft of work prior to that, which many colleagues have been involved in, looking at how we create a broader team-based approach to care delivery, not just within primary care, but between primary care, the community sector, voluntary sector, mental health, and indeed social secondary care, as I was referring to earlier. How we create a one team-based approach focused on defined populations and what the sweet spot for that defined population might be. And myself and some colleagues sort of led some of the work that was involved in defining neighborhood networks around 30,000 to be a sort of size around which you can coordinate care, integrate services, but also not lose that great value of primary care to provide personalized care for those people who need it. So that's the sort of work that's been done around the background to support development of primary care networks. And I think Olivia will talk a little bit more about what that means from 2019 onwards. But my key hope, Neil, is that as we think about primary care networks and their opportunity, we need to keep in mind the importance of population health, how we look at the broader determinants of health, and how we improve how we work alongside the environmental and social factors that govern the way in which people live their lives, and how we think about the context of comorbidities, multiple conditions, how those things are thought about not only in terms of the individual conditions in a narrow way, but also about how we organize the way we provide care to sort of target people who need that in the most effective way, which is essentially the basis of population health management. Neil, I'm going to stop there if that's okay, because I'm sure that it's probably more value in hearing from other colleagues. So shall I just leave it there for the moment?
Thank you very much, Nav. No, there was a huge amount of value packed into a nice punchy intervention there. Really helpful to have that that sense of the trajectory of some of these conversations about how can primary care best make a difference to these issues. And I couldn't agree more with your point about population health and the need to be thinking about the social determinants. And I know that's going to come into the conversation this morning. So that has set up very nicely for Olivia now to sort of talk about the national policy framework and where that might now take us. Olivia is head of public participation at NHS England, but through the pandemic, she's been working with incredible focus on a lot of these health inclusion issues, and particularly in relation to homelessness health. So really delighted to welcome Olivia. Over to you.
Thanks so much, Neil. I need to start with a little shout out. Firstly, to say hello, Pam Esther. It's really lovely to see you. Pam's just down the road from me in Keighley, and we've known each other way too long. It would be embarrassing if I said how long we've known one another. And also to Fazana Hussain, who's with us, who's an amazing GP practicing in London, leading her primary care network. So much to learn from stuff that's already happening out there. So thanks for that introduction, Neil. I've kind of got two parts to what I want to talk about. I want to talk a little bit about kind of multiple long-term conditions and inclusion health, or people, wider populations, because I think part of the challenge is we often see the condition, not the person. And as Nav was talking about, this isn't just about primary care fixing the problem. Primary care cannot fix the health inequity, health inequalities problem on its own, because health inequalities are about income, education, housing. If you think about Maslow's hierarchy of needs, those people who don't have their needs met at the bottom of that hierarchy are the people who experience the worst health inequalities. Primary care can help and is a contributor to all of that, and actually could be an organiser and an advocate locally. And I think that's where primary care networks will really come into their own, thinking about that advocacy and that organisational collaboration role that primary care has to contribute to improving health outcomes for everybody. So the populations I'm particularly interested in, I think we've got a lot of complex language around all of this. So we talk about inclusion health populations. Who are they? So you've talked previously on these sessions about the sort of the health inequalities curve. You live in an affluent neighbourhood, you experience less health inequalities than if you live in a very deprived neighbourhood. If you want to multiply the worst, most deprived neighbourhood in the country by at least 10, that's the health inequalities that people from inclusion health populations experience. So people from Gypsy, Roma traveller communities, people experiencing homelessness and homelessness families. In fact, there's an APPG on this morning about the experience of homeless families, because children born into homelessness and who experience homelessness as children go on to have the worst health outcomes in the population. There's loads of evidence. If you have a look on the Queen's Nursing Institute website, they're hosting an awful lot of evidence around how people's experiences of life really impact on their health outcomes. People who've experienced the criminal justice system, equally, they're people that generally people don't want to have anything to do with. All of these populations, they're somebody else's problem. And I think we have to accept the fact that there is societal stigma around different populations, and we have to start really thinking about how inclusive we are, because we're really not very inclusive. So things like access. So access to general practice, access to any service that requires you to navigate it. How do you do that if you're not from this country? If English isn't your first language, if you don't read and write English, if you don't have digital access, all of those things create access barriers into services. And that's not just into primary care, that's into any service, including voluntary sector services. So the voluntary sector, and my background's in the voluntary sector, that they're not a panacea of great practice. The voluntary sector can often be incredibly difficult to navigate in its own right. We silo people into specialist service areas. So you're diagnosed with diabetes, you go to see a diabetist, I can't say the words, you go see a doctor who sorts out diabetes, or a nurse who sorts out diabetes. You're not your diabetes, because actually you might have diabetes, you might also have high blood pressure, you might also have all sorts of things, and you might also be homeless. So if you're homeless, how do you access diabetes services? How do you access care to get your leg ulcers treated? We did quite a bit of work with an amazing GP called Dr Caroline Schulman through COVID, really trying to raise awareness of people's experience of homelessness at end of life. So people who've experienced years and years of homelessness tend to die in their 40s. So their frailty score on the frailty index will be that of an 80-year-old. And they're left to die in hostels with no care. There are hostel staff who do their best, but literally no healthcare going into those hostels to care for them. And that's if they're in a hostel and they're not dying on the street. So how do we in our end-of-life care services really think about those people who don't fit the stereotype of living in a house, of having some of those basic needs met? How do we really start to think about personalising care around the person, not the condition that they present with? And we have been talking about this for decades. And we seem as a system to be totally unable to be able to think outside of those sorts of commissioning silos, where we commission a diabetes service, we commission a cancer service, we commission these things. Nobody joins them together. So how, as an individual, trying to navigate those and deal with your life, where if you don't rock up at your probation appointment, you're going to end up back in prison, or you've got to move your van on because the local authorities decided you're on an unauthorised camp. We put that there are so many other things going on in people's lives, and then that they have to encounter an incredibly complex health system. So we've got square pegs and round holes going on, literally for anybody who isn't quite straightforward. So how do PCNs help with all of that? So PCNs for me aren't just about general practice, and certainly the policy intent behind it. Nav mentioned the primary care homework that this was built from, and it needs to go further. So we think about, and one of the reasons I'm delighted to see Pam here today is Pam's chair of Keighley Healthy Living Network. The Healthy Living Network is a network. There's a clue in the network name of primary care networks. It's not just about general practice. It's about collaboration and partnerships across all of those services and support that's available for people, so that we can improve access, we can streamline access, and we can put the person at the centre. Instead of saying, no, we can't do that for you, go away. Actually, well, we're not best placed to do that, but let me introduce you to, let me support you to get to the place that can care for you and can provide you with what you need. And starting to organise care around what matters to people, not what matters to commissioners or service providers. Because if we start with what matters to people, then we start to be able to support them in much more meaningful ways. So primary care networks should not just be general practice, they should include the local authority, they should include communities. And we've seen amazing work through COVID where primary care has been connecting with volunteers and community organisations, distribution of food, access to appointments, access to pharmacy, all of that, bringing together all of the assets in our communities with a common cause. And I suppose there's a bit of a challenge in this about how do we then continue that partnership and collaboration post-COVID. Primary care networks do have all of these new roles. So we've heard a lot about social prescribing link workers, but there's also care coordinators and health coaches, clinical pharmacists, physiotherapists, community paramedics, all sorts of different roles that can be introduced into the primary care team, but as part of that holistic community-centred approach. And I think there's a real opportunity for primary care networks to really think outside the box. So if you think as an individual primary care network, you might not have very many Gypsies and Roma travellers on your patch in your neighbourhood, but across the local authority area, there probably is. So how could you collaborate and bring together some of those additional roles to work collaboratively at place level rather than just within the neighbourhood? And also, I mean, there's been, again, sorry, it's all about where I live, basically. Airwolf Craven PCN have done some amazing work with the vaccine rollout, where they've been seconding people from community organisations and voluntary organisations to help them to connect with communities in real and meaningful ways on their terms. It shifted the way that primary care network's working. It shifted their thinking about what community engagement really needs. And it shifted their delivery models into being much more controlled by the community rather than being controlled by the provider. And so I think I will sum up to say primary care networks, huge opportunity to really be asset-based, huge opportunity to really join up together. But there's a challenge for people on this session as well. If you're from the voluntary sector, and I'm going to pick on Diabetes UK because there was lots of people in the chat from Diabetes UK, how do you see the whole person and not just the diabetes? How do you help to act as that connector to enable people to access the care that they need? And how do you help to really be inclusive and reach out and welcoming to all of those people who can't get access to services because society has stigmatized them so much they're thoroughly excluded? And that's all I'll say.
Olivia, thank you very much indeed. Thank you, Nav, as well. I should say other areas are available other than Keighley. You know, very nice area it is. Other areas are available. Thank you very much indeed. What a wonderful way to set the scene. Welcome back, everyone. We hope you had good mini breakouts. Apologies if you were the one speaking when the Zoom hammer came down. I'm going to pass straight over to Neil. Neil.
Thanks, Rich. Yes, I hope we've had some useful conversations, and that's prompted some good questions to whack into the chat. While we're waiting for those to come in, it just struck me it might be useful to get reflections from Nav and Olivia on that challenge that Olivia made about the role of the voluntary sector in this space, and what might enable the sector to join things up better, but also to do that in concert with that description that Olivia gave of commissioners pulling things together around people. So, I mean, are there any good examples that either Nav or Olivia have seen of people starting to think differently and act differently about that?
Neil, shall I kick off? So in terms of examples, I mean, there's a lot of great examples across the country. I noticed Fazana's on the group, and she may be able to tell you about the great work she's doing to support health inequalities in Newham, particularly around knife crime, which requires a real multi-agency field. But I want to give you an example from Brazil, if I may, where actually where some sites in England are trying to replicate. So basically, the idea here is how you organise provision of care across households and not just individuals. So looking at clusters of households, circa 200 to 250, and how you provide a coordinated response to all members of that household, whether they're older people, whether people with multiple long-term conditions, whether they're young people, whether they're people with particular health needs. And that the role of an individual community health worker is to target all the participants of that household and not just people with single organs or single diseases, and in a way of trying to ensure that the right coordinated response is given to all of those people, both in terms of health promotion, health understanding, navigating the complex system that we've created, and providing a genuinely coordinated response to the various agencies that exist. And early findings are that this is starting to have some real impact, both in the quality of people's lives and particular reduction in activity, both in primary and secondary care. So I'll stop there, but if anybody wants to find out a little bit more about that, please do let me know.
Thanks, Nav. And did you have thoughts on that, Olivia? And also, just interesting to see, looking at the questions coming in, a lot of people focusing on challenges around capacity and resources. So, whether that's about how you integrate things effectively at community level, or whether that's about professionals having the headspace to be able to have those effective conversations with the voluntary sector. So it'd be great to hear your thoughts on that.
Yeah, so just very briefly building on Nav's point, there's a GP in, I'm going to say Lambeth, but it could be Lewisham. It's London. I live in Yorkshire. They begin with an L, called Vikesh Sharma. Vikesh has taken the work that's been going on in Brazil and adapted and developed the household model, starting with a Portuguese-speaking community in Lambeth. It's fantastic work. I'll find the website and post it in the chat that they've got set up. They've also got a community-led vaccine website, communicating in multiple different languages and with people from different cultural backgrounds and so on. It's absolutely just bob on work, and it'd be really interesting to see where that goes. I think that it's an interesting question, this question about capacity, and I think I'd throw it back and say, are we sure we're using the capacity we've got to best effect? Because if we keep doing what we've always done, we'll get what we've always got. So is it time that we actually had some radical conversations about what doesn't work? So we might have been doing it for ever such a long time. So for example, winter night shelters for people experiencing homelessness. They don't get people back into accommodation, employment, education, having somewhere safe to call their own. They're a real sticking plaster. So if we keep resourcing and funding flowing to night shelters, are we just continuing the sticking plaster? Do we all need a radical rethink about how we best use the resources that are available to us? So for example, I used to run a Sure Start programme. Yes, it was a lot of extra money, but the big change that was needed was the way in which people worked. It wasn't actually about money. It was about people's ability to collaborate, to really work in partnership, to let go of some power and control, and start to be much more collaborative in their approach. So I'm not sure more money, for shorthand, is always the answer. I think we need to look really radically at how we're utilising the resources we've already got available to us.
Great, thanks very much. So with lots of really good stuff in the chat, which we're not going to have time to deal with right now, but I'm sure people will take into the bigger breakout sessions shortly. So I'm just going to move us on now to introduce our next two speakers to set us up for those sessions. And firstly, I'm really pleased to introduce Yasmin Ibison, who is the Programme and Partnerships Manager at Black Thrive. And she's going to give us an overview of a programme that's really relevant to what Nav and Olivia both said at the start about the wider social determinants of health. So this is their project looking at employment and health in Lambeth. So over to you, Yasmin.
Thank you, Neil, and good morning, everyone. Thanks for inviting me to present today. I thought I'd just do a bit of an introduction about Black Thrive Lambeth in general. So we are a partnership between communities, statutory organisations, voluntary groups and the private sector. And we work collaboratively to reduce the inequalities that negatively impact the mental health and well-being of Black people, specifically in Lambeth, and those inequalities that lead to poorer socio-economic outcomes. So our priorities as an organisation are to see Black residents thrive by centring the voices of Black communities in evidence and knowledge production, as well as embedding race equity in systems change. So the employment project specifically that I manage seeks to improve the employment outcomes of Black people with long-term conditions in Lambeth. So Black people disproportionately bear the burden of long-term conditions in Lambeth and acquire multiple long-term conditions up to 10 years earlier than their white counterparts in the borough. Conversely, Black people also have a less positive experience of the labour market, so they're more likely to be unemployed. And when they are employed, they are disproportionately engaged in low-paid, insecure and precarious work. And we also must recognise the impact of structural discrimination and racism within, but obviously not limited to the workplace and healthcare settings, and the impact that this has on one's health and well-being. So this project seeks to disrupt this kind of self-reinforcing negative relationship between poor work and poor health, whilst also gathering data and evidence for what works in terms of employment and healthcare support for Black people, specifically with long-term conditions. So how are we doing this? And I guess the question is, what role can primary care networks play in supporting or leading on some of this change? So I kind of mentioned this already, but within this project specifically and all of Black Thrive Lambeth's work more generally, we focus on systems change, as I guess we think that this has the potential to provide long-term solutions which promote equity and justice for everyone, really. So within the employment project, there are 4 categorized areas where our activity kind of falls into these systems change areas that I thought I'd provide an overview and kind of reflect on how PCNs could link into some of these systems change activity that this project is currently carrying out. So the first area is strategic learning and mental models. So here our focus is on data, and some of the work that we're doing is to strongly encourage or urge all organisations that have a role in employment and health to systematically collect equalities data and make this data openly available. So alongside the numbers, the quant data, it's really important to also consider qualitative data and lived experience. And when we're analysing this data, we really encourage or support organisations to apply, in this case, a Black lens, but a race equity lens to the data. And we kind of want this to be seen as a norm throughout the healthcare and employment settings. Then this data should be used to inform policy and practice. So primary care networks would be clear about what they're doing to address any disparity that the data kind of highlights, and encourage or support robust data collection and analysis from their community health partners as well. So I already mentioned policy and practice, and that's the second area of systems change. So policy, practices, and resource flow. So my question would be, how could equitable employment and healthcare outcomes for residents with long-term conditions be embedded within policies, practices, and ways of working in all stakeholders across primary care networks? So I guess one quick reflection that I had is around recruitment policy. So I know that I think there's around, is it 12 or 11 positions which make up kind of the additional roles that are funded through primary care networks, and could lived experience be prioritised for certain roles, and what impact would this have? Similarly, how do resources flow throughout the network, and which resources could be leveraged to maximise outcomes for residents? I'm really keen on the idea of a community-based delivery of support and being implemented that kind of devolves resource to local communities themselves to effectuate change. Thirdly, we have relationships and connections. So we've kind of spoken about this already, Olivia and Nav spoke about this, but I guess as primary care networks seek to understand the landscape in which they operate, it's really important to build trusting relationships and connections with community partners that work specifically on the ground with marginalised groups, and embed these partners into the system to kind of create those referral pathways. So we've spoken about treating the whole person rather than the condition, and this is something that at Black Thrive and myself I'm really, really passionate about. So avoiding siloed working, as we all know, this leads to duplication of efforts, poor communication, and basically ultimately missed opportunities. So within the employment project, we're actually working to shift employment support service landscape in Lambeth from one based currently on competition towards a more collaborative network of providers that deliver mutually reinforcing activities. So we've kind of coined this No Wrong Door. And the No Wrong Door Collective is a group of, currently I think it's 5 or 6 of the borough specialist employment support providers who are working within this collaborative system, sharing data, resources and referrals, as well as learning and best practice. So basically the idea is that wherever a person ends up, whichever service a person initially ends up to, they will be redirected to the one that, or signposted to the one that is the most appropriate for their needs, so that there's no wrong door to a person seeking help. And then finally, because I know I've not got long, there's this question around power and decision making within systems. So we know already that certain systems do not work for some groups, because these communities are marginalised, or they're minorities, or they do not wield institutional power. So empowering communities to have agency and control in shaping the solutions to issues that affect them personally can really radically shift top-down power dynamics that we see so often. So my question is, could primary care networks interrogate whose voices are missing from the conversation around service improvement? Who is marginalised by the traditional PPG or patient participation group routes, and how can we ensure that these forums are representative of the local population as a whole, and of those groups, as Olivia did mention, that are so often excluded, stigmatised, kind of not brought into the conversation around services. How this is working within the employment project at Black Thrive is that we are trialling, I guess I would call it quite a radical community-led decision-making process. So we've organised a community working group, which is comprised of Black Lambeth residents with lived experience of long-term, of either managing one or more long-term condition themselves or caring for someone with a long-term condition. And then this working group has the power to distribute a pot of grant funding. So it's a £300,000 pot of grant funding to pilot community-led projects that are trialling new approaches to employment support for Black people with LTCs. So this working group kind of decides on the grant parameters, is involved in the application process, is involved in kind of promoting the fund, sifting the applications, and then ultimately deciding on who gets this money. So far, they have funded 13 projects, 10 of which are Black-led and 5 of which are disabled-led. So it's kind of an approach that really prioritises lived experience and kind of experts by experience in empowering community members to kind of decide for themselves on what they think would work to help them with the issues that they're facing. I'm going to stop there. I hope that's given a bit of a flavour of the work that we're doing. I'm really looking forward to the kind of breakout session where we can discuss this and some other questions in more detail, and how, I guess, primary care networks can adopt similar ways of working to support systems change activity. But yeah, thank you very much.
No, thank you, Yasmin. That was some really powerful stuff in there, and lots for the breakout group to think about soon. Not least, I mean, what struck me particularly was the point she made about thinking about opportunities around recruitment, that shift from competition to collaboration, and then that stuff that gets right to the heart of it around agency and decision making, where the power and control lies. So lots to get a great discussion going there. Thank you. So we're going to move on now to hear from Rachel Brennan, who coordinates the Health Now network at Groundswell, and she's going to give us an overview of their program, which is all about learning from people who are experiencing homelessness, about what works for people experiencing homelessness. So kind of fits in quite nicely with what Yasmin was just saying about agency and control. So over to Rachel.
Thanks so much. And yeah, Yasmin, I was like nodding along so much to that, and so many points resonated. I have got a few slides, so if we can move on to them, just so I don't forget anything that I wanted to say. So I appreciate Olivia's covered some of this in her conversation about inclusion health earlier. So just to give you a bit of an introduction to Groundswell. So we're an organisation that's been around since the 90s, and we really believe that the solutions to homelessness are going to come from people experiencing homelessness themselves. So crucially, that they should be given the opportunity to participate. I won't go into too much detail about what we do, but some of the projects that we do. So we run a homeless health peer advocacy project. So Groundswell deliver this in 12 London boroughs. And we've also supported organisations across the UK and Ireland to set up their own peer-led services based on our model. We have an Insight and Action team, which is our research team, and we work with people who've experienced homelessness to train them as peer researchers. So they support us to develop research plans, to develop research methodologies, to carry out the research, to analyse the data, and to work together to create those solutions and recommendations. Underpinning everything we do is progression. So 2/3 of our staff at Groundswell have got experience of homelessness themselves. With all of our volunteers, they get supported with progression. So the idea is that they are being supported to move out of volunteering. We don't want to keep people in volunteering, so we're supporting people to get into education, training, or employment. Health Now is the national programme that I work on, which is really about taking the good practice that Groundswell have developed and working with organisations in different areas to implement that. So doing peer research to evidence health inequalities, doing peer advocacy, so we're supporting people who are currently experiencing homelessness to access and engage with the healthcare that they need, and working with alliances, so in areas that we work, setting up local alliances with key stakeholders from housing, homelessness, health, local authority, with people with lived experience to understand what the barriers are and to work together to develop solutions. So we go on to the next slide, please. Yeah, so just want to talk a little bit about homelessness and health and why it's important and why we think it's really important for primary care. So health issues are often one of the common causes of why somebody becomes homeless in the first place. When someone is homeless, their health often deteriorates, and that's not just rough sleeping. You know, we had a conversation in our earlier breakout group about how, you know, poor housing can impact health, because somebody being at risk of homelessness can impact their health. Homelessness is a risk factor for trimorbidity, so the experience of physical health issues, mental health issues, and substance misuse. And like Olivia pointed out before, if we're talking about long-term conditions, people experiencing homelessness can have multiple long-term conditions alongside substance misuse and mental health, and face really significant barriers in accessing the healthcare that they need. The next statistic is some research that was done by the charity Pathway, who I would really recommend you go onto their website. They've got loads of resources available. So in 2011, as part of working to develop their Pathway a hospital in reach programme for people experiencing homelessness. They found that people who were experiencing homelessness attend A&E 6 times as often as the general population. When they do attend, they're 4 times more likely to be admitted, and once admitted, stay 3 times longer. Now, that's not the best form of access for them in terms of their healthcare, but also for the NHS. And what we know about people experiencing really significant multiple health conditions is that when they do go to A&E, when they get admitted, it's only the presenting issues that will be looked at, not that kind of holistic whole picture that doesn't just take into the health needs of people, but also those wider social determinants of health. And that's what we want, really. It's working out, you know, like how accommodation fits into that, how benefits fit into that, how well-being, food, nutrition, social connection all fit into that picture of good health. Because people have significant health issues and have barriers accessing healthcare, the average age of death of a homeless man is 47 and is 43 for a homeless woman, which is almost half that of the general population. And what we know is that if that was being caused by, you know, similar figures for either obesity or smoking, there would be, you know, a lot of influx, a lot of funding, a lot of research, a lot of services to prevent that happening. And we feel that it should be the same. And then the big thing, I think, for primary care is that some research that was done by University College London found that in a study of deaths of people who are experiencing homelessness, nearly 1/3 of them died from treatable medical conditions. So if they got access to healthcare they needed in a more timely manner, they wouldn't have died. So if we go on to the next slide, please. So yeah, just to kind of introduce some of those barriers, really. So some of them are practical. So I know Olivia was talking about the Maslow's hierarchy of need. You know, if people can't get their immediate needs met, that they're generally going to, you know, go to those first. So thinking about accommodation, thinking about food, thinking about, you know, if they've got family, that putting, you know, their family's needs before their own. If people have substance misuse, you know, often that's going to come higher on their level of needs and accessing healthcare. Lack of funds to travel to appointments. I think, you know, there's a lot of disruption that's associated with people having no fixed abode. So whether they are rough sleeping, whether they're sofa surfing, if they're being moved around different temporary accommodations, you know, all of that can make it really difficult. You know, what we know from how the healthcare service is changed is that, you know, if you present at one A&E or if you get referred from your GP, you're not always going to get referred to the closest practice. You might not know where that is. You might not have the skills, confidence or resources to be able to find where that is, let alone then get there. Personal is a really big issue. So there's a lot of lack of trust between people who've experienced homelessness and statutory services. So building that trust can be, you know, really difficult, particularly if there's been bad treatment, not just by healthcare staff, but also other people using the service. So I previously managed a homeless healthcare service in Manchester that was part of a general practice. So there would be experiences of, you know, people in the waiting area making comments about how somebody presented or moving away from them. And if you think about, you know, if that happened to one of us and how that would make you feel, you wouldn't want to go back there. People presenting at A&E and being heard their health issues being discussed, or their, you know, presentation being discussed. And then there's the systemic. So, you know, we create a health system, which is an amazing health system, which serves a really broad population. But in doing so, we often marginalise people. So for people who are experiencing homelessness, being asked for proof of address or proof of ID, getting appointments by text message, getting appointments by letter as standard, and not always, you know, being offered alternatives. The move towards digital and remote healthcare, you know, prior to the pandemic, I think it was really difficult if people had to phone up at a certain time of day. I think when they're rough sleeping, or if they don't have access, you know, they have to wait for their key worker to come into work at 9 o'clock before they can ring the GP, or their day centre to open. Now, you know, difficulties navigating healthcare systems with digital and remote healthcare, whether that's online telephone consultations. You know, we've just done some research in Greater Manchester, Birmingham and Newcastle, and in every area we had participants that had said that they'd been asked by their GP to send photos, but they didn't have a phone to be able to do that, or the funds. You know, we've heard experiences of people ringing at 8 o'clock in the morning, being kept on hold for 30 minutes. So by the time, you know, they've got through, their credits run out. And just difficulties navigating the healthcare system. You know, if you get an appointment for choose and book and you need a PIN number and filling in an online form, all of those can, you know, really provide a lot of barriers to accessing healthcare. So if we go on to the next slide. Yeah, so I've very much oversimplified this, and I was certainly thinking that when Olivia was speaking before about thinking about, you know, primary care is part of the answer. But I suppose the things that, you know, I really wanted to think about or get people to think about today is one is access. And listening to people speak, you know, I've been reminded of, you know, an inclusion health doctor in America that I was fortunate enough to meet, said to me, don't worry about the people in the waiting area, worry about the people that aren't. And I suppose I'm running out of time, so hopefully we'll get to talk about this in our breakout group. But I think that's the big thing that I want to think about today, is not worrying about the people that are on your practice list, worrying about the people that aren't. And we've got a real opportunity with primary care networks to look at populations and not practices, and to really work together to make sure that we're meeting the needs of them. And I suppose what my I did have a few questions actually about patient participation groups and recruitment and employment of people with lived experience similar to Yasmin. But I suppose my question would be, how can the new roles created within primary care networks be utilised to improve access and engagement for people experiencing homelessness? Thank you.
Rachel, thank you very much indeed. Thank you, Rachel. Thank you, Yasmin. Say welcome back, and we hope that you had constructive breakouts. Time is always against us. We'd have loved to have run those for a week, well, possibly not a week, but slightly longer. But we hope you had really good conversations as part of those discussions. Again, we're sort of running at quite a fast pace this morning, and so if you've got further reflections following today, we'd love to hear from you. We'll be sharing contact details in just a moment. We will be finishing at past, so we have a sprint to the finish, which we're going to start by just hearing brief feedback from each of the breakout groups. Eve, could we come to you first? Eve, do you want to say which group you're in and sort of just a couple of your key points?
Thank you, Rich. Yes, I was in the group with Rachel and the Groundswell example. Brilliant discussion. Again, I'm going to be really brief and just pick out a couple of themes that emerged. I think really strongly theme emerged for us around access. So we're talking about particularly, for example, people's rights to GP registration, and it's absolutely brilliant that people are campaigning around those rights, but our group were encouraging people to dig deeper. So a person might be registered with a GP, but actually, when did they last visit? Where is that GP service located, for example? And I think that also linked to that, the encouragement for each of us to think about whose voices are missing in all kinds of decision-making and service spaces. We talked about the importance of a range of practical and behavioural support alongside medical interactions. So thinking particularly around pastoral care, legal and welfare, employment, mental health and well-being. So really strongly linking in a kind of multidisciplinary approach and a really diverse pool of community health partners as a critical response to this challenge. And then finally, we were talking about participation, so really a commitment to work with people who have experienced these issues and invest in those people who have lived experience to represent their views to decision makers. And then finally, just to say that Rachel made the point that if we take inclusion health issues really seriously and we get it right for people that have incredibly complex needs or for who the system isn't really set up as it is geared at the moment, it means that actually we would be getting it right for everybody, which I think is a really powerful, motivating thought.
Eve, thank you very much indeed. Sounds like you had a great discussion. We're going to come to Callum next. Callum.
Thanks, Rich. And yes, I was in the other group led by Yasmin. And just three really quick points to make from our discussion. Had a lot of discussion around kind of data. So actually, we've got a lot of data out there, but is it disaggregated in the right way? Are we thinking about using that data in the right way or applying kind of a racial lens to it to make the most of it? But also appreciating that there's the anecdotal that kind of sits behind those numbers, that sometimes it's going back to the individual people and hearing from them that can really make the most powerful case to PCNs and PCN leaders. We also had a bit of a call to kind of the VCSE and other community partners to actually really engage with PCNs. They're still felt to be really GP-led, and GPs are trained in that medical model, so actually they need to hear from kind of other voices who can speak to the wider determinants of health. And then a final, very, very broad summary point, coming back to Olivia's point at the beginning of today, actually some of that change does need to come from above. We do need, some of it might require a different way of thinking about commissioning, a different way of kind of allocating what limited resource we have. But likewise, in terms of the research we commission to look at these issues, actually maybe we need to appreciate that to really engage with different communities, that takes longer, that might cost more, but actually the results can be really valuable at the end. That's all from me.
Callum, thank you very much indeed. Eve, Callum, sort of a perfect succinctness of feedback. To come to Neil for a brief closing reflection and discussion of what comes next. Neil.
Thanks, Rich. And yes, thanks to everybody that's taken part today. It's been an incredibly rich set of conversations. Thanks obviously to all of our speakers, Nav, Olivia, Yasmin and Rachel. I've been really pleasantly surprised today. I thought this was going to be a really interesting discussion. What I'm delighted by is how quickly we got straight into the practicalities, how much consensus there was about some understandable actions that collectively we can take. So our commitment, our letter to the future from the Richmond group will be to make sure that we take some of those clear areas of focus that have come out of today's conversation into the roundtable we're hoping to organise with decision makers and the wider influencing work that we will do going forward. But also what's been really valuable for us is that we're going to be doing some thinking over the next few months about where our multiple conditions work goes in the future over the next few years, because it will stay at the heart of what we do as the Richmond group. And I think some of the themes that have come up in the conversation about the way that the part that the voluntary sector can play and the way that it can and should interact with other services around this agenda is really going to help us to do that. So thank you very much. Look out next month for our piece of ethnographic research, which is going to be really relevant to some of the things we talked about today. We'll make sure that you know when that's coming out. And thank you all so much for taking part and for all your insights.
Neil, thank you very much indeed.